There's a moment, dear, a very specific, very narrow window that decides whether a heart attack becomes a story someone survives or a story someone else has to tell. It's not measured in hours. It's not even measured in tens of minutes. Sometimes it's measured in 3. I've watched this moment happen. I've had a patient sitting across from me months later, alive, walking, talking, who by every statistical measure shouldn't have been. Not because of some miracle drug, not because of a hospital they happened to be near, but because of what happened in the first few minutes before any paramedic, before any doctor, before any hospital was even in the picture. Most people think surviving a heart attack is entirely up to the medical system, that it's about how fast the ambulance arrives or how skilled the ER team is, and those things matter enormously, but there is a small, specific set of things a person can do in that first critical window that genuinely change the odds. Not folk remedies, not viral myths, real, physiologically grounded actions that can buy the time your heart needs. Today, I want to walk you through 3 of them, the same window that gave my patient a second chance. The first thing worth understanding is why aspirin, of all things, sits at the center of emergency heart attack response. It isn't because aspirin is a powerful drug in the way we usually think about powerful drugs. It doesn't dissolve a clot, it doesn't restore blood flow, and it doesn't stop the underlying blockage. What it does is interrupt one very specific, very dangerous process that's actively making things worse in real time: the runaway formation of new clotting material on top of an already narrowing or blocked artery. To understand that, you have to understand what's actually happening during a heart attack. In the vast majority of cases, a heart attack begins when a plaque, a buildup of fat, cholesterol, and other material along the wall of a coronary artery called ruptures. That rupture exposes the inside of the artery wall to blood in a way it's never exposed under normal circumstances, and the body's clotting system reacts to that exposure as if it were an open wound. It rushes to seal it. Platelets, small cell fragments that circulate in your blood specifically for this purpose, flood the area and begin clumping together, forming a clot. Under normal circumstances, this is exactly what you want your body to do. If you cut your finger, this is the system saving you from bleeding out. But inside a coronary artery that's already narrowed by plaque, that same clotting response becomes the mechanism that finishes closing off the vessel entirely, cutting off blood flow to part of the heart muscle. This is where aspirin's very specific, narrow function becomes so important. Aspirin works by blocking an enzyme called cyclooxygenase, which platelets need in order to produce a compound called thromboxane A2, essentially a chemical signal that tells other platelets to clump together and join the growing clot. By interrupting that signal, aspirin doesn't dissolve the clot that's already there, but it does slow down how quickly that clot continues to grow. In a situation where every additional minute of blockage means more heart muscle losing oxygen and starting to die, slowing that growth can be the difference between a heart attack that damages a small section of tissue and one that damages a much larger one. This is also why the method of taking it matters as much as the decision to take it. Swallowing an aspirin whole means it has to travel to the stomach, begin dissolving there, and get absorbed through the stomach lining, a process that can take a meaningful amount of time, especially during a medical emergency when blood flow to the digestive system may already be reduced as the body prioritizes essential organs. Chewing the aspirin instead breaks it down mechanically before it ever reaches the stomach, dramatically increasing the surface area exposed to saliva and the lining of the mouth, where absorption can begin almost immediately. Studies looking at platelet function have shown that chewed aspirin produces measurable anti-clotting effects within minutes, compared to a notably slower onset when the same dose is swallowed whole. In a scenario where minutes determine how much heart tissue survives, that difference in absorption speed is not a minor technicality, it's the entire point. The typical guidance involves a standard adult aspirin, generally in the range of 162 to 325 milligrams, chewed rather than swallowed. It doesn't need to be a specialized emergency formulation. The regular aspirin many people already have in a medicine cabinet is what's being referred to here. The chewing itself doesn't need to be prolonged or thorough. Even partially breaking the tablet apart with the teeth before it's swallowed accelerates absorption compared to swallowing it intact. That said, this is not a universal instruction, and this is the part that gets lost when the technique gets simplified into a quick tip. Aspirin is not appropriate for everyone in every circumstance. People with a known allergy to aspirin, a history of significant bleeding disorders, active stomach ulcers, or those who have been specifically told by a physician to avoid aspirin due to another medication interaction, should not take it during a suspected heart attack without guidance from emergency medical personnel. This is one of the many reasons calling emergency services first, rather than trying to self-treat in isolation, remains the foundation of everything else. A 911 dispatcher can often provide real-time guidance on whether aspirin is appropriate for that specific situation based on what the caller reports about their medical history in that moment. It's also worth being clear about what aspirin is not doing. It is not treating the heart attack. It is not a substitute for emergency medical care, and it is not going to resolve the underlying blockage on its own. Its entire value lies in narrowing the gap between the onset of symptoms and the arrival of professional treatment, buying time by limiting how much worse the clotting process gets while that gap is closing. This is why it sits alongside other immediate actions like calling for help and reducing physical exertion, rather than standing alone as a solution. It's one piece of a small, coordinated set of actions designed to do one thing: preserve as much heart muscle as possible during the narrow window before more advanced treatment becomes available. What makes this particular technique so significant in a survival story is precisely this narrow, well-defined mechanism. It isn't a vague suggestion to do something. It's a specific biochemical intervention, backed by decades of clinical research, that targets the exact process actively causing additional damage in real time, which is part of why it's included in emergency cardiac guidelines used by ambulance services and emergency departments around the world, even though it's simple enough to be carried out by anyone reaching into their own medicine cabinet. The instinct during a heart attack is almost always the opposite of what actually helps. People feel a tightening in their chest, a strange pressure, maybe pain radiating into the arm or jaw, and their first response is often to keep moving, to walk it off, to try to get to a phone, to attempt to drive themselves somewhere, to pace around the room because standing still feels unbearable when something feels so wrong. That instinct, as understandable as it is, works directly against the one thing the heart most needs in that moment: a reduction in demand. To understand why stopping and sitting or lying down matters so much, it helps to think about what a heart attack actually represents physiologically. It isn't simply the heart stopping. In most cases, it's a section of heart muscle being deprived of oxygen because a coronary artery has become blocked, either partially or completely. The heart muscle downstream of that blockage is still alive, still trying to function, but it's now operating with a severely reduced or completely cut off oxygen supply. Every contraction that segment of muscle attempts to perform under those conditions accelerates cellular damage. The less oxygen available, the more precious every remaining bit becomes, and the heart's oxygen demand is directly tied to how much work it's being asked to do. Physical activity increases that demand dramatically. Walking, climbing stairs, carrying something, even the adrenaline-driven urgency of trying to get to help quickly, all of it raises heart rate and blood pressure, both of which increase the workload placed on the heart muscle. In a healthy heart, this is a manageable, even beneficial response. But in a heart actively experiencing an infarction with part of its muscle already starved of oxygen, that increased workload accelerates the rate at which the affected tissue deteriorates. Essentially, activity during a heart attack asks an already struggling section of the heart to work harder, precisely when it has the least capacity to do so. This is why the guidance is so consistently specific. Stop whatever you're doing immediately and get into a position, sitting upright or lying down, whichever feels more comfortable and allows for easier breathing, that minimizes physical exertion. Sitting upright is often preferred over lying flat, particularly if there's any accompanying shortness of breath, because it can ease the work of breathing and reduce the sensation of pressure in the chest for some people. But the specific position matters less than the underlying principle: stillness. The goal is to bring the body's overall oxygen demand down as close to resting levels as possible, giving the heart the best chance of preserving the muscle tissue that hasn't yet been damaged. This principle directly contradicts one of the most common and dangerous instincts during a heart attack, the urge to drive to the hospital rather than wait for an ambulance. Beyond the risk of losing consciousness behind the wheel, which is a real and serious danger on its own, driving itself represents a form of activity and stress that increases cardiac workload at exactly the wrong time. Ambulances, by contrast, are equipped to monitor heart rhythm continuously, administer oxygen, provide medications, and respond immediately if the situation deteriorates into cardiac arrest, none of which is possible in a car. Every minute spent behind the wheel is a minute the heart is working harder than it needs to, without any of the safety net an ambulance provides. There's also a psychological dimension that intersects with this physiological one. Anxiety and panic, which are extremely common and entirely understandable responses to the symptoms of a heart attack, trigger their own physiological cascade, the release of adrenaline, increased heart rate, and elevated blood pressure. This is the body's natural stress response, but during a heart attack it works against survival rather than for it, compounding the very problem that stillness is meant to solve. This is part of why emergency responders are trained to speak calmly and deliberately to patients experiencing a heart attack, encouraging slow breathing and stillness rather than urgency. The instruction to remain calm isn't about comfort. It's a direct intervention aimed at reducing the physiological stress response that would otherwise increase the heart's oxygen demand even further. Positioning also plays a role in what happens if the situation escalates. Heart attacks can, in some cases, progress into cardiac arrest, where the heart's electrical activity becomes chaotic and it stops pumping effectively. If someone is sitting or lying down when this happens, rather than standing, walking, or driving, the risk of a fall-related injury is dramatically reduced, and it becomes easier and faster for bystanders or emergency responders to begin CPR immediately without needing to first move or reposition the person. This is a detail that often gets overlooked in conversations about stillness during a heart attack, but it's a meaningful part of why this technique is emphasized as strongly as it is in emergency medical training. None of this means someone experiencing a heart attack should simply sit and wait passively without taking any other action. Calling emergency services remains the essential first step, and other measures like chewing aspirin when appropriate can happen while seated or lying down without requiring any additional physical exertion. The principle isn't inactivity in the sense of doing nothing, it's the elimination of unnecessary physical movement specifically, while still taking the small, low-exertion actions that genuinely help. Unlocking a door for paramedics, for example, might involve a few steps, but it's a brief, necessary action rather than sustained physical exertion, and ideally happens early before symptoms progress further, or is delegated to someone else nearby whenever possible. What makes this technique so critical and so frequently underestimated is that it costs nothing, requires no equipment, and can be implemented immediately by anyone, anywhere, the moment symptoms begin. It doesn't require medical training or medication access. It simply requires recognizing that in this specific moment, doing less is doing more, and that the instinct to move, rush, or push through is, physiologically speaking, working directly against the heart's ability to survive what's happening to it. There's a strange psychological pattern that shows up again and again in heart attack survival stories, and it has almost nothing to do with medical knowledge and everything to do with human hesitation. People know, on some level, that something is seriously wrong, and yet the first response is rarely to call for help. It's to wait, to see if it passes, to take an antacid, assuming it might be indigestion, to tell themselves they'll call if it gets worse in another 10 minutes. That 10 minutes, multiplied by however many times it repeats, is often the single largest and most preventable source of delay between the onset of a heart attack and the arrival of care that can actually change the outcome. This hesitation has a name in emergency medicine. It's often referred to as denial time, and research into heart attack outcomes consistently identifies it as one of the most significant factors determining survival and long-term heart damage. It isn't a failure of intelligence or awareness. It's a deeply human response to an overwhelming, frightening situation, one that the brain often processes by minimizing rather than confronting. Chest discomfort becomes probably just stress. Jaw pain becomes, I must have slept wrong. Shortness of breath becomes, I'm just out of shape. Each of these rationalizations feels reasonable in the moment, and each one adds minutes, sometimes tens of minutes, to the delay before emergency services are contacted. To understand why that delay matters so much, it helps to return to what's happening physiologically. When a coronary artery becomes blocked, the section of heart muscle downstream of that blockage begins to die if blood flow isn't restored. This isn't an abstract, gradual process. Cardiologists often describe it with the phrase, time is muscle, because the relationship between time and damage is remarkably direct. The longer the blockage persists without treatment, the more heart muscle is permanently lost, and that lost muscle doesn't regenerate. It's replaced by scar tissue, which doesn't contract or contribute to the heart's pumping function the way healthy muscle does. This is why the specific techniques of early treatment, clot-dissolving medications, angioplasty to physically reopen the blocked artery, stent placement, are so time-sensitive. Their effectiveness is measured not just in whether they're eventually performed, but in how many minutes elapse between symptom onset and their initiation. Calling emergency services first, before attempting any other action, is what sets that entire timeline in motion. This might seem obvious, but in practice, a significant number of people call a family member first, or drive themselves to a hospital, or wait to see if symptoms resolve, all of which delay the moment when actual emergency medical response begins. Calling 911 does something none of those alternatives can replicate. It dispatches paramedics equipped with cardiac monitoring equipment, oxygen, and medications who can begin treatment the moment they arrive, sometimes even before reaching the hospital, and it alerts the receiving hospital in advance, allowing them to prepare a cardiac catheterization lab or clot-dissolving treatment before the patient even walks through the door. This advance notification is a critical, often underappreciated piece of the process. Hospitals that receive advance notice from paramedics that a suspected heart attack patient is inbound can activate their cardiac response team immediately, cutting down the time between hospital arrival and actual treatment, sometimes by a significant margin. Driving yourself or having someone else drive you, by contrast, forfeits every one of these advantages. There's no cardiac monitoring during the drive, no ability to intervene if the heart rhythm becomes unstable or if cardiac arrest occurs, and no advance warning to the hospital. If a driver experiencing a heart attack loses consciousness, there's also the danger of a vehicle collision, putting not just the patient but others on the road at risk. Even in a best-case scenario where none of these complications occur, the simple absence of monitoring and treatment during transit means the clock keeps running with no medical intervention happening at all, while an ambulance transforms that same transit time into active treatment time. The instruction to call first also matters because of what a 911 dispatcher can offer beyond simply sending an ambulance. Trained emergency dispatchers can provide real-time guidance while help is on the way, including instructions on whether taking aspirin is appropriate, given the caller's specific medical history, how to position the body for comfort and reduced cardiac strain, and if the situation deteriorates into cardiac arrest before paramedics arrive, step-by-step instructions for performing CPR. This turns the phone call itself into an active part of the treatment process, not simply a request for transportation. It's a resource many people don't think to use, largely because panic narrows attention to the immediate physical sensations rather than the tools available in that moment. There's also a broader pattern worth naming, the tendency to underestimate symptoms specifically because they don't match the dramatic clutch your chest and collapse version of a heart attack that's been popularized in film and television. Real heart attacks often present far more subtly, especially in women, older adults, and people with diabetes, where symptoms can include unusual fatigue, mild discomfort in the back or jaw, nausea, or a vague sense that something is wrong without classic chest pain at all. This mismatch between expectation and reality is part of why hesitation happens so often. People are waiting for a symptom severe enough to justify what feels like an overreaction, when in fact the appropriate threshold for calling emergency services is far lower than most people assume, and erring on the side of caution costs nothing beyond the temporary inconvenience of a call that turns out to be unnecessary. What makes this particular action so foundational, more than any single medical intervention that follows it, is that it's the action that makes every subsequent intervention possible. Aspirin, monitoring, clot-dissolving drugs, emergency angioplasty, none of it happens without this first call, and every minute spent hesitating before making it is a minute those interventions are delayed. It's the one technique in this entire framework that isn't about physiology directly, but about behavior, timing, and the willingness to treat a frightening, ambiguous set of symptoms as seriously as they deserve to be treated immediately, without waiting for confirmation that never comes in time to matter. So let's bring this back to where we started, my patient, sitting across from me months later, alive because of what happened in the first few minutes before any ambulance arrived. It wasn't luck in the way we usually think about luck. It was 3 specific, learnable actions, taken in the right order at the right moment, that bought enough time for everything else, the paramedics, the medications, the catheterization lab, to actually work. Chewing an aspirin, if it's safe to do so, slows the clotting process that's actively closing off the artery in real time. Sitting or lying down immediately reduces the heart's oxygen demand, giving already starved muscle tissue the best possible chance of surviving. And calling emergency services first, before anything else, sets in motion every subsequent intervention that actually saves lives. The monitoring, the hospital's advanced preparation, the treatment that begins the moment paramedics walk through the door. None of these techniques require medical training. None of them require equipment you don't already have. What they require is recognition, recognizing the symptoms early, resisting the instinct to minimize them, and acting immediately instead of waiting to see if they pass. That single shift from hesitation to action is often the entire difference between the outcome my patient had and the outcome so many others don't get the chance to have. Time is muscle. That phrase isn't dramatic language. It's a literal physiological fact. Every minute that passes during a heart attack without action is heart tissue that doesn't come back. But every minute saved by knowing what to do and doing it without hesitation is tissue that survives, function that's preserved, and in many cases, a life that continues. I share stories like this one not to frighten anyone, but because so few people know these 3 specific things, and knowing them costs nothing until the moment they matter more than anything else. If this is the first time you've heard these techniques laid out clearly, that's exactly why this conversation matters. If this changed the way you think about what to do in those first critical minutes, subscribe so you don't miss what comes next. And in the comments, I'd genuinely like to know, had you heard about any of these 3 techniques before today, or is this new information for you?